I'm going to discuss this topic by dividing into three broad categories: what, how, and why. So, what is the intimal hyperplasia, and how does it happen, and why is it clinically important for a vascular surgeon? So, we see various scenarios in our daily vascular clinics. A patient who has undergone previous bypass surgery coming to us after 1 year with late graft thrombosis. Patient who has undergone balloon angioplasty for a critical limb coming with restenosis. Patient who undergone stenting coming with stent stenosis. Also, the CKD patients who have undergone EV fistulas coming with late fistula thrombosis, and patients with carotid endarterectomy who has come to us with carotid restenosis. So, intimal hyperplasia is a common culprit in all these cases. So to start with speaking with simpler terms, intimal hyperplasia is basically a healing response to vascular injury. It is a type of pathological vascular remodeling which leads to luminal narrowing. So it is also known as arteriosclerosis, neointimal formation, and vasculopathy. It is also a predecessor for the atherosclerosis. So it is defined as a process in which intima becomes thickened due to the presence of smooth muscle cells and the proteoglycan-rich extracellular matrix located between the endothelium and internal elastic lamina. If you see at this image, the left half of the image is the normal vessel lumen, and the right half of the image is the diseased vessel lumen. If we see, as we all know, the vessel wall comprises three layers, basically tunica, intima, media, and adventitia. In the left half of the image, as we see, the smooth muscle cells are mainly compressed in the tunica media between the external elastic lamina and the internal elastic lamina. But as we see in the right half of the image, the smooth muscle cells have entered into the tunica intima between the basement membrane and the internal elastic lamina, along with the extracellular matrix deposition. So which is contributing to the luminal narrowing. So intimal hyperplasia can be adaptive or pathological. So adaptive intimal hyperplasia we usually see in the stages of development where there is a shift from the circulation from fetal to post-fetal. So in these cases, the closure of the ductus arteriosus and ductus venosus, there is a physiological closure and the anatomical closure. The physiological closure is the one which occurs immediately due to hypoxia, where the vasoconstriction causes the physiological closure. It further goes into the anatomical closure where the intimal hyperplasia plays the major part. So the pathological intimal hyperplasia is the one which we are worried about. This we have seen in a majority of our revascularization procedures like bypass surgeries, angioplasty, stenting, AV fistulas, and endarterectomy. So how does intimal hyperplasia occur? So it is basically due to smooth muscle cell proliferation and proteoglycan-rich extracellular matrix deposition in between the endothelium and internal elastic lamina of the tunica intima. So in brief, the vascular endothelial cell is the chief regulator of the vessel homeostasis. So any injury to the vascular endothelial cell activates the immune response, which causes downstream activation of the vascular smooth muscle cell of the tunica media. This further leads to the smooth muscle cell proliferation and migration into the tunica intima, which further leads to extracellular matrix deposition and neointima formation finally. So the endothelial cell is the chief cell which regulates the vessel homeostasis. It regulates the vascular tone by producing the nitric oxide and hydrogen sulfide, which relaxes the medial smooth muscle and causes the vasodilation. It regulates the coagulation cascade by preventing the exposure of the subendothelial matrix. It regulates angiogenesis by secreting various growth factors, and also it prevents the inflammation. So injury of any sort to the vascular endothelial cell may be due to metabolic stress, vein preservation, anastomosis, during stenting, during the hydraulic method is like for example when we distend the vein during the vein harvesting, it can also lead to the vascular endothelial cell injury, and also during the transplantation. So any sort of vascular injury leads to downstream events like first the nitric oxide, hydrogen sulfide production is decreased with increased expression of the ICAM, VCAM, P-selectin adhesion molecules, which further leads to vasoconstriction, platelet aggregation, and leukocyte infiltration. These collectively produce several cytokines, growth factors, and chemokines. So all these products through various cellular and subcellular pathways finally culminates to the vascular smooth muscle cell activation. So till then, the contractile vascular smooth muscle cell quiescent phenotype is shifted to the proliferative synthetic phenotype. So So once it is activated, the smooth muscle cell proliferates and migrates into the tunica intima, which further causes the proteoglycan predominant extracellular matrix deposition in the tunica intima. So finally leading to neointima formation. So if you see the chronology of the neointimal hyperplasia, so it can arbitrarily divided into hyperacute stage lasting for hours, acute stage lasting from days to weeks, and chronic stage lasting for months. So following endothelial injury, initially the platelet aggregation, activation, and the coagulation cascade activation occurs. Due to the endothelial injury, the inflammatory pathway sets in, and the cytokines and chemokines further leads to the smooth muscle cell activation, proliferation, and migration into the tunica intima. So the finally extracellular matrix deposition and vascular remodeling occurs, which leads to the neointimal hyperplasia. So endothelial injury and exposure of the subendothelial matrix first initially leads to the platelet accumulation, which occurs rapidly till first 8 to 10 hours and then decrease from the 3 to 7 days. Simultaneously, there is apoptosis in the media and the intima due to various mechanisms. So which usually starts within 1 to 2 hours and abates by 4 hours and then increases again by day 7 and there is a marked decrease by day 14. So also vascular smooth muscle cells proliferation starts beginning by day 7 and there is a peak proliferation by day 14 and then it returns to baseline by 28 days. But in the conditions where the re-endothelial proliferation and neointimal hyperplasia can continue till 12 weeks. So finally, the last process is extracellular matrix accumulation, which is minimal in the first 1 or 2 months in the histological specimens, but there is a dramatic increase from 3 to 6 months. So after 3 months, there is an increase in the intimal thickness is due to the extracellular matrix accumulation rather than smooth muscle cell proliferation. So till now, there is a inside out versus outside in hypothesis. Till now, what we have seen is the inside out hypothesis where the injury to the endothelial cell has resulted in the neointimal hyperplasia development. But there is also various studies where the outside in hypothesis is also supported. So according to this outside in hypothesis, the vascular healing drive is from the adventitia rather than the intima. This is based on the several numerous stem cells in adventitia, and there is high levels of a monocyte chemoattractant protein expression in the areas of the intimal hyperplasia. So in these cases, it is regarded that the adventitia is the main cause of the neointimal hyperplasia rather than the intima. So there are several clinical factors also which influence the intimal hyperplasia development, whether it is a degree of development or it's a length of development. So it's the depth of injury, it's a length of injury, excessive distension, if there is a compromised outflow, whether hyperlipidemia, and also the diabetes. So if you see the problem burden, there is a one study which is showing the rate of restenosis after bypass or endarterectomy at 1 year is 20 to 30%. And also the rate of secondary occlusion for the endovascular procedures is 30 to 60%. If you see the clinical scenarios, whether the patient is undergoing angioplasty or stenting. So the restenosis following angioplasty is mainly due to the platelet aggregation, intimal hyperplasia, elastic recoil, and negative remodeling. But restenosis following stenting, the elastic recoil and negative remodeling are negated because of the stent deployment. So in these cases, platelet aggregation and intimal hyperplasia are the main factors playing in the restenosis. So, a patient undergoing angioplasty may have the following consequences or complications. Patient may have the develop the dissection or the elastic recoil, which can be immediately addressed by stent placement. So the patient can have the occlusion, which can be addressed by stent placement, or we can view the thrombolysis. Or on the long run, the patient develop intimal hyperplasia, where we can use brachytherapy, cryotherapy, using the drug-eluting balloons for the angioplasty, and also less frequently used drug-eluting stents for the peripheral arteries. So once intimal hyperplasia is sets in, this undergoes remodeling. If it is a positive remodeling wherein the thickness of the wall increases, keeping the lumen wall patent, then the patient can our procedure might not have the complication of the occlusion. Whereas if the patient has the negative remodeling of the intimal hyperplasia, then he can finally land up in restenosis or occlusion. So, if you see the consequence of stenting or have the more prolonged inflammatory response than the balloon angioplasty due to the deployment of the stent. There is a generalized finally it is covered by the adherent protein, predominantly fibrin, and the leukocyte infiltration occurs, which finally culminates to the neointima formation within the 2 weeks. So we also should know about the stent, which is deployed adjacent to the injured media or the lipid core, has a robust intimal hyperplasia reaction. So we usually see that the stent restenosis is more predominant at the proximal and distal stent ends than in the body. This is because the struts of the stent cause the more injury than the body of the stent. And also stent oversizing also we should take care of, where uh, oversizing to a greater extent lead to the greater instant restenosis. The second is the drug-coated balloon usage. The rationale behind it is the stent itself can stimulate the inflammation. So the ways, searching for the ways where we can avoid the stent deployment in these stenosis cases, they have come across the usage of drug-coated balloons, wherein the chemotherapeutic or immunosuppressant drug is administered at the preferred lesion by contact and pressure, which so that there is a delay in cell proliferation. So the widely used drug-coated balloons are mainly predominantly paclitaxel coated or sirolimus coated. So the paclitaxel is a chemotherapeutic drug which acts in the cell cycle dividing state, where it stabilizes the microtubules, but it is indiscriminate to any proliferating cell. So along with reducing the intimal hyperplasia, it delays the re-endothelialization also, and also it results in the increased smooth muscle cell loss. So sirolimus is an immunosuppressant drug where we commonly use as a vascular surgery. We use in the malformations also. It acts on the mammalian target of rapamycin receptor. But the sirolimus it is also indiscriminate to any proliferating cell, but it has improved patency and the safety profile than the paclitaxel. So it is seen that drug-coated balloons, with the usage of drug-coated balloons, there is improved primary patency and decreased target lesion revascularization at 5 years for femoropopliteal segments, but no similar results were found for the infrapopliteal segments. So then we come to the drug-eluting stents. The drug-eluting stents are predominantly coming to use for the coronaries in 2002, but the peripheral vascular it has come only in 2012. It is also both the sirolimus or paclitaxel coated. It improves vessel patency by inhibiting the smooth muscle cell proliferation. But because it doesn't act on one particular cell, it delays wound healing also, and also there is it induces the endothelial tissue factor expression, which causes increased thrombosis. So majority of drug-eluting stents now are paclitaxel coated. So next is the autogenous vein graft usage. So veins usually implanted to the arteries undergo arterialization by the endothelium, intact endothelium, and there is increased medial thickness by smooth muscle cell proliferation. But also after implanting into the arteries, the veins undergo dilatation due to the drop in shear stress. This commonly leads to the outward remodeling with increased wall thickness but preserved vessel lumen. But there are the focal areas of injury which can occur during the procedure, which lead to intimal hyperplasia and causes the stenosis and thrombosis on the later on. So the surgical causes for this include the graft dissection with adventitial, it may be the adventitial injury also, and over distension during the vein dissection, or when we check for the leaks after the vein harvesting. Also the storage media which we use, and also the skin marker which we usually use to orient the vein, and also the length of the vein graft, how is it orienting, and also the distal outflow. So it is seen that the patients with poor outflow has more intimal hyperplasia reaction than the patients with normal outflow. And there are some certain non-modifiable non-surgical causes. The hyperlipidemia, smoking, hyperfibrinogenemia, hyperhomocystinemia, APLA, and lipoprotein A levels. So insertion of a vein graft. Following the vein graft insertion, there can be endothelial cell injury, which leads to the inflammatory reaction and inflammatory cell infiltrate, and also the smooth muscle cell injury. So this combinedly leads to the progenitor cell activation and endothelial cell proliferation and smooth muscle cell proliferation. So which finally culminates in the intimal hyperplasia. So if the intimal hyperplasia remains stable, then the patient, the graft remains stable for the patent for the long time. If the patient has the intimal hyperplasia is progressive, then the patient can have the restenosis or the patient present with graft occlusion. So there are several preventive measures, protective measures which we can take during the vein bypass graft handling. So to minimize the graft handling and dissection, and to avoid over distension while we check for the leaks after the vein harvesting, and the solution, the buffer solution storage, and to tailor appropriate length so that we prevent excessive kinking or also the excessive tension on the shortened vein graft. And also we should be the non-toxic orientation marker should be used while orienting the vein graft, and also the external support or stenting, where some studies have been done where the stent has been placed outside the vein graft, which has shown the improved results. So there are certain studies where the prevent 3 and prevent 4, where they have used the pharmacological measures to improve the patency of the vein graft by decreasing the intimal hyperplasia. They have used a drug called edifolizide, which is a decoy oligonucleotide in the patients where they are planning the vein graft. But both prevent 3 and prevent 4 studies have not showed any are not shown no any effective improvement than placebo in such cases. So next is the usage of prosthetic grafts. So the grafts which you commonly use are the polyester, that is Dacron graft, or the PTFE graft. But both grafts have shown poor performance in the infrapopliteal reconstruction. So when they have examined the explanted PTFE grafts at various stages, so they have seen at 5 to 24 days there is RBC deposition along with fibrin coating and the macrophages at the anastomosis. At 11 to 48 months, there is a single layer of endothelial cells and fibrin at the anastomosis, and there is anastomotic hyperplasia with smooth muscle cells. But after 94 to 149 months, there is no further progression in the intimal hyperplasia. So endothelial growth in the graft is usually at the anastomosis and at a few centimeters beyond. But there can be the new endothelium through the entire length of the graft, which occurs by the transmural endothelialization, which depends on the porosity of the graft. Grafts main Grafts fail commonly at the distal anastomosis due to the intimal hyperplasia. This is due to the several factors like arterial injury due to surgical anastomosis, flow disturbances due to the configuration of the anastomosis, and also by compliance mismatch by the transition between the stiff graft and the compliant artery. So there are several methods by which we can minimize this by the composite graft or by the vein cuffs at the distal end. This is the first one is the Saint Mary's boot, then Miller's cuff, Taylor's patch, and the Linton patch, where we use the cuff of the normal native vein, even though the patient in these patients we are using the prosthetic graft. So in the patients with the prosthetic graft insertion, the luminal surface has thrombosis, which leads to the inflammatory infiltrate and the adventitial ingrowth. This finally leads to the endothelial cell proliferation, smooth muscle cell proliferation, and extracellular matrix deposition and migration with intimal hyperplasia. So this on the long run can the intimal hyperplasia, if it is the intimal hyperplasia is stable and there is no further progression, the graft remains patent even on the further follow-up. But if the intimal hyperplasia is progressive, then the patient again can have the significant stenosis or graft occlusion, which we might need to intervene. So finally coming to dialysis access graft. There are two distinct sites of intimal hyperplasia. One is anastomotic site, which is more if we use PTFE graft than the native vein, and also in the floor of artery, which is same in both graft and the native vein dialysis access. So the anastomotic site intimal hyperplasia is mainly due to the surgical trauma and flow disturbance. The AV graft, there is a high failure rate of the AV graft due to intimal hyperplasia predominantly at the venous anastomosis. This is due to the significant mismatch in the elastic properties between the graft and the vein. So management of AV graft intimal hyperplasia is widely studied. So it is typically focused on venous anastomosis. But traditionally, it was advised to have to undergo the patients with AV graft. Uh, uh, it is advised to undergo surgical revision with patch angioplasty and the venous anastomosis. But currently, the first line management is the balloon angioplasty. Because the patient, even after the open surgical revision and patch angioplasty, again the etiology is the same, and the patient again can present with recurrent intimal hyperplasia and stenosis. So, however, the patient requires a repeat intervention. So, it is better to consider the first line management as balloon angioplasty than to go to direct open procedure. The drug coated balloons and bare metal stents are used, but the results were not satisfactory. So, concluding, intimal hyperplasia is universal in all kinds of revascularizing procedures which we see. So histologically, the vascular endothelial cells and smooth muscle cells are the main culprit in the pathophysiology. So, however, there's no single lucky molecule or the magic bullet identified as it, so that we can address this issue properly. So the measures to minimize the degree of intimal hyperplasia is better to be adopted rather than searching for the treatment. Thank you for your attention.